Are we good? All right. Good evening, everyone. And on behalf of Angelo State University, I would like to welcome you all to Angelo State University's National Minority Health Panel. My name is Brandy Dunham. My name is, no, it's on. Is it on? Okay. My name is Brandy Dunham, and I'm a mental health counselor here at Angelo State University, and I will serve as a moderator for tonight's panel discussion. April is National Minority Health Month, a time to raise awareness about health disparities that affect racial, ethnic, and other minority populations, and encourage action through health education, early detection, and control of disease complications. One of the underlying goals of the panel is to reduce the stigma around underrepresented populations receiving resources and help in the areas of medical and mental health care. Tonight's format will include an introduction of the panel, followed by a question and answer session with the panel. For those joining us online, please submit questions for the panel using the online forum. Before I introduce tonight's panel, it is my pleasure to introduce Dr. Flor Madero, the Chief Diversity and Inclusion Officer, as well as an Associate Professor for Angelo State University. Please give a warm welcome for Dr. Madero.
I'm not going to tell them about the little stool you have back here. I am not going to talk about that, sister. I'm Flor Leos Madero. I am a professor of communication and the Chief Diversity and Inclusion Officer. And it is my privilege to be here tonight to be able to listen to this panel. I'm looking forward to your information. At Angelo State University, when we look at our numbers in terms of our Hispanic, our Black, Asian, and international students, we are at 49% enrollment out of 10,500 students. So half of our population belongs to an underrepresented community. Now, we know that mental health has a stigma just overall, but we also know that in communities of color it's even more stigmatized. So tonight we have this great opportunity to be able to learn, educate ourselves, but also to be able to learn about, even if it doesn't affect us, or if it's not something that we need at this moment, it doesn't mean we're not going to need it later on, or that we won't be able to be a resource to someone. I know that when I was teaching more courses and being in the classroom, typically I would say about 4 to 5 students out of a class, about 25, who would eventually be able to find their own community and be able to speak up and say, I suffer from depression or anxiety, ADD, it is several things, right? And so one of the things that we would talk about in class is about how loneliness is not about numbers. You can be in a large space with a lot of people and still feel very alone. I hope that through today's education, you will be able to find, those online and those here, you'll be able to find that you are not alone, but also that Angelo State University, as we adhere to our values of community and diversity and inclusion, that you know that there are people here, that the RAM fam is not just a phrase, it's a thing. Also hope that you will put a face with the name. The Office of Diversity and Inclusion is here to help you. I am here to help you. And if there's anything that I can do for any of you online or in this room, I am happy to help however I can. Thank you so much for the opportunity to speak tonight, and I look forward to this panel. So I'll send it back to Brandy. Thank you.
Thank you, Dr. Madero. Now to introduce the members of our National Minority Health Panel. I will introduce each panel member. The panel member will then provide a brief biography of their experience and area of expertise. I will begin by introducing Mrs. Adrena Gonzalez, RN, clinical nursing instructor here at Angelo State.
Thank you. Apologize for the- for, parents' background in medical services. I worked correctional care. Also worked at sexual assault nurses Anna. Adults have so my wish. I work full time here at. But that's,
Next,
Thank you.
next, we will introduce Mrs. Monica Frey, social worker for West Texas Counseling and Guidance here in San Angelo, Texas.
So I am a licensed medical social worker. I initiated my services as an intake specialist in Oklahoma City. The public defender's office advocating for clients that had non-violent crimes, trying to connect them to resources and advocating for release in fact. It was a new program in Oklahoma City, so I got firsthand working in the prison system and also connecting to resources. After that, I came here to West Texas and I worked in veteran services as myself. I was a 13-year veteran with the United States Air Force where I was a medic. There I worked with Vietnam veterans, groups, resources, but now I am a clinical community mental health where my main focus right now is working with clients with trauma, working with clients using evidence-based modalities that we can meet them where they are. Advocating still as a social worker because that's what I'm going to do to the day I die. And so the reason I'm so grateful to be here is the fact that as I came back to you, however, I think it's important for people to see that mental health and is important for our community. There aren't very many therapists that look like me in rural areas. So I want my face to be known to say, hey, we got people at West Texas Counseling and Guidance. We're really focused on all of that.
Thank you. And now I will introduce Toby Redden, Doctor of Nursing Practice, Shannon.
Hi, my name is Toby Redden in State University. I started in nursing in 2007. To advance my career at North Dakota State University in Fargo. 2015, and since then I've been working provider in this role. I started out in rural Minnesota, a small little town called Pelican Rapids. High population of Somali refugees, so that was kind of my real first with some very drastically different cultural experiences. How to approach that, particularly with mental health, when they over it's a completely different language, culture, everything. Then we relocated back to San Angelo, Texas, approximately 6 to 7 years ago, and I've been shocked at the amount of mental health that I started encountering on a daily basis. The frequency, the acuity of our is just skyrocketing, and I hope that I'm here today along with these other panelists that we can break down some of those stigmas related to mental health access and provide more of services and kind of everybody else was saying, just put a face out there so you know that we're here for you. We are here to help people where we can.
Now I will introduce Dr. Christopher Haddad, cardiologist, Shannon Hospital.
Thank you, Brady, for having me come this evening. I actually grew up in Vicksburg, Texas, which isn't far from here. I'm an interventional cardiologist. I'm the director of the cardiac cath labs at Shannon. I did my undergraduate at SMU in Dallas and med school at UT, and then I did my internal medicine training at Mayo in Minnesota. Minnesota has a large population of Somali refugees. So I can speak to some of the things that you spoke with earlier. And then I did my cardiovascular training and interventional training back in Houston, and have been back in San Angelo for about 11 years. And I think Brandy asked me to come this evening to help speak a little bit about some of the disparities we see, particularly in cardiovascular care and certain populations, particularly populations of color in our area and in the country particularly. So thank you for having me this evening.
Thank you for coming. Okay, now we will go into our question and answer segment of this panel. Okay, so for the first panel, so the way this is going to work is you can answer if you would like to, and y'all can have a discussion if you would like. So it's not aimed at just one person, it's aimed at the panel. Okay, so our first question is, how can organizations decrease the stigma associated with accessing mental health resources for people of color within their organization?
Start. Okay, so I actually learned this. I think it's really important that we are aware of the systems in place at our organizations, and if they are not only accessible, able to be understood, but if there are, what are the barriers to those care? And a lot of times finances are a barrier, but it can be as simple as not seeing anyone that looks like you, where you don't feel accepted, so you don't want to go in. It can even be as simple as you're not providing resources in my language, or even saying, hey, you know, I see that you don't have even access to an interpreter so that I can get what I need across without feeling like you're judging me. It can be little things like that. And really it starts with knowing what your community looks like. And many times we're not going out to the community, finding out what are the needs you might be afraid of what we do. So for me, I think it's extremely important to have those boards where we have community members who are giving us firsthand experience of what their barriers were to care so that we can address that.
Thank you. And would anyone like to add to that, or are we good? Okay. All right, next question. Are there certain medical conditions that disproportionately affect ethnic minorities?
I didn't write that question. I know I'm saying, but I'd like to speak to that. So, you know, I think without a doubt, particularly in our area, diabetes and hypertension or high blood pressure absolutely disproportionately affect patients of color, particularly the Black population and Hispanic, non-white population. Now, both of those diseases are endemic in the population to begin with, but if you look, probably an order of 25% of the Hispanic population will be diagnosed with diabetes. 20 to 25% of the Black population at some point will be diagnosed with hypertension. Both of those numbers far outweighs their counterparts in you know, the non-Hispanic white population. So there's clear disease processes that disproportionately affect populations of color. Now, is that genetically based? Is there a multifactorial reason for that? That includes diet, lifestyle type things, probably a combination of both. But in my field, both of those risk factors are some of the biggest risk factors for development of heart disease. So I think particularly those two disorders we see disproportionately affect those communities which then, of course, unfortunately, disproportionately puts those populations at higher risk of developing heart disease throughout their adult life.
Yeah, I can personally speak to that, knowing everyone in my family has diabetes and all of those diseases that you spoke of.
So we consider diabetes almost, we treat patients with diabetes almost the same as, almost the same is not a great terminology, but having diabetes, essentially you'll be treated as someone who has known coronary artery disease or atherosclerosis of the heart arteries or blockage in your heart artery. So we treat patients, meaning our goals for blood pressure, our goals for cholesterol management, and patients with diabetes, we treat them as in patients we know who have obstructive disease, who've had heart attacks, who've had revascularization procedures like stent procedures or bypass procedures, because we know that risk factor so commonly leads to heart disease that it is almost synonymous with having heart disease. So, and then unfortunately, you see that diabetes is so endemic in these populations that it disproportionately affects those populations.
Do you see them in the later stages or earlier stages?
Without a doubt. So, and that goes up into a big question, and I don't want to dominate, but that is some of the disparities in care. So if you look at cardiovascular medicine, unfortunately, all Americans have a higher risk of death from heart disease than any other disease. If you add most of the leading causes of cancer, it still won't compare to dying from heart disease. So probably close to 700,000 Americans will die from some form of heart disease this year. Those numbers disproportionately affect patients of color or non-white Americans. We almost, if you look at patients across the board that present with acute coronary syndromes or heart attacks, patients who present later or more into their illness oftentimes are patients of color, probably for a multitude of reasons: lack of care, lack of availability of care. You know, there's, I don't know if the right forum, but there's all sorts of, you know, institutionalized things that probably lead to this. And, you know, we throw around terms, but there's, you know, structural, probably racism type terms or policies that we've looked at as a whole, where you have lack of access of care, lack of availability of care that leads to this. But then at the same time, we even see patients that present often get undertreated with the same disease process. So that changes from institutional. So we, you know, there was a study done a few years ago, and the American Heart Association looked at patients presented with heart attacks or congestive heart failure, and found that patients that were Black were less often seen by cardiologists in the hospital or in the ICU than white patients. And it's clear that patients with acute heart failure seen by cardiologists tend to do better long term. So why is that happening? You know, so those are you know, and that probably goes beyond structural or institutional things. I mean, because you're talking about patients maybe in the same facility, or, you know, so those are broader questions. You know.
I am personally work, and a lot of the clients that come in for anxiety, they're being referred to me because they've done all the research or done all the labs, and they're not finding these cardio problems, and they're not understanding where the anxiety is coming from. So that's when they come to me, and then it's many times that they're or they are prescribed lisinopril and different things for blood pressure, and they don't like the reaction. They don't like the the effects of the medication, but instead of them speaking and talking to their cardiologist or their nurse and saying, hey, this is not helping me sexually, emotionally, they're causing other effects. And so they're coming to me saying, I'm not taking that medication. And I'm like, well, you need to go talk to your doctor because it's important. But as a therapist, I can't do anything about that. And I see that, but they're too afraid to have those conversations or they feel rushed. And so then, because your time is limited, because you guys are seeing so many people in the hospital. So what do I do as a therapist to help my client understand the importance of going back and having those conversations with meds?
Yeah, it's difficult. I mean, I think probably education, even from a medical staff or patients who are sort of data driven, and I put myself there. We come up with a cocktail. Like you said, we have to be on this medicine, this medicine. This is what improves survival. If we do this, we improve survival. And then maybe that education with people who patients might have more of that comfort level, that might feel more able to communicate, well, this is why this is important. This is why they're doing this.
But that takes time.
Right, or breaking down those barriers. And, and I think those are the questions. I think most of us as practitioners would find that the balance or the art is finding what patients, every patient I see, you try to get a sense of we're on the same page, we're good, they're doing, so you adapt the time with in the clinic, in, for instance, the outpatient setting, and I think we all strive to be better, but feel like we try to adapt. Okay, this patient needs more time. Listen, I don't know if it's always time, as we try to make, but we're coming across the way, so just even saying an ACE inhibitor, do they know what I'm saying?
Right.
Or hypertension, does that make sense? So there's so many different dynamics to it, adherence and regimens, presentation when symptoms come, so we don't avoid late presentations. So it's so multifactorial that it's hard to pinpoint. I think the first step is, and this might sound cliche, is recognizing that there is a problem. And that's, even amongst ourselves providers, medical providers, and to look at some of the statistics and realize how undertreated certain groups are, and that's consistent. So we even fail, on patients where we know, for instance, in my field, acute coronary syndrome, when someone comes into a heart attack, it's quite clear that doing procedures that revascularize and open arteries have benefits in extending life, and it is quite clear that populations of color don't get those procedures at the same rate as other populations. So why is that? I don't know. I don't have an answer to that. But acknowledging that that's true, I think first you have to start there, and then try to break that down and realize that beyond just structural problems, we have other problems.
Thank you. Okay, so we do have a question from our online viewers, and it is, what inspired you to choose your career path?
Well, I'll start. So I think I grew up in a very rural, small Texas town. When I say small, I graduated with 11 people in my class. So I'm not kidding when I say rural. I didn't have access to healthcare like this. I mean, I kind of grew up in a household that it was kind of suck it up, buttercup, let's go. My parents loved us. I went to all of our well-child checks and everything, but I was kind of the kid that got bucked off the horse, and my dad told me to get back up there, get back on it. We're not whining. 2 days later, take me in and broken off kind of thing. I mean, that was kind of how we rolled. So I think as I went into college and I got to see some of the access, I went to nursing school at the University of Texas in El Paso. And I had never even had access to healthcare like at my fingertips. There was a healthcare clinic on campus. I remember at King Guy one day, I woke up, I was like, oh my gosh, I don't even know what to do. I called my mom. She's like, hey, go to the healthcare clinic. I was like, I don't, how do I do that? Like, it's embarrassing to say, but I was like 19 years old. I was like, I don't know how to do that. You know, so every day now that I'm with my students, we call parents all the time in the room. We talk about medications all the time. I mean, it's just step by step. So I think I knew that I wanted to help people. I just didn't realize how I wanted to help people until it was later on in life. And hopefully I'm able to fill that void. And I do relate well to people that are in those rural communities. But I can also relate to people that came from inner cities, and, you know, we can work together and figure it out. So I think my inspiration was growing up without it.
Thank you.
I would also add to that. I too grew up in a very rural area. Graduating class of 10 people.
Oh, come on, I know I had to.
So I can also personally speak to the lack of emergency medical care for individuals, especially minorities who are, you know, when you grow up with an asthmatic youngest sister, and the nearest medical facility is an hour away, you have to learn how to handle an airway in that situation, and just kind of grew up that way. And so, you know, one particular being numerous, but one particular time when I almost lost her. I was able to see, as a high school student, I was able to see what nurses do and how they treat patients. And that really stuck with me. So that was my initial inspiration for coming into. And I can also attest to the fact that there is such a huge lack of care for rural facilities. It's quite dangerous for individuals who have existing illnesses and who live so far away, or like the nearest medical facilities are 3 hours away, 4 hours away. And so geography plays a huge role with regard to the kind of disparity that we see with our patients. So my path was all over the place. I grew up in Virginia, went into college, flunked out of college, joined the military and became a medic. And there I loved everything I did. I was deployed. I had amazing experiences, but there was a lot of trauma in my time in the military. So right at 13 years, I decided that it's probably the best decision for me at this moment, and I got out. And I had no clue where I wanted to be. I was like, I've done it a lot. I've been all over the world. What do I do at 33 years old now? And I'm old. So then I had a tax station in Oklahoma, and I went to the University of Oklahoma thinking I was going to get my degree in nursing. Decided I hated microbiology. So I was like, oh, no, never, not going to do this. Although I had my LPN license from Challenging the Board, so I am an LPN, I worked at the ER, just could not do micro. So I went to my own social worker, because as a disabled veteran, I was able and afforded someone that could be with me and help me navigate my transition into the civilian world. And there they were like, you know, you've done a lot. You should be a social worker. And I was like, what? I don't know. And so literally that's what I said. So then I took my first intro to social work class, and it changed my life. Literally changed my life. I am a social worker. I believe it. I am to die a social worker until the day I die. So from my initial course at University of Oklahoma until my final graduate course at the University of Baylor University, I have gotten so much experience, but it was through my life experiences. It was through my failures. It was through my wins. It was through my community. It was through my support systems that led me to the career path that I chose. So now it's just all about I'm gonna give it back.
Awesome, thank you.
I should have gone first. Again, I grew up not far from here, but my father's position, I think I had a sense, you know, as you guys are in undergrad, you maybe have an idea when you go to undergrad what you wanted to do. You know, I started as a biology major, so I'm sure I had that idea of going to medical school, but I also had a minor in philosophy, so I didn't, you know, I didn't know, but I had an idea, but for me, the board decision, or that tree was deciding what specialty to do after I got into medicine. And I chose cardiovascular medicine because, particularly the field I do interventional cardiology, so it's a wide spectrum of doing procedures on people when they're sick and having heart attacks. And here, you know, you're allowed the ability to, I have a general practice where I treat people with lipid disorders or cholesterol disorders, and we talk about, you know, what they did last weekend, and it's just a general sort of internal medicine to, you know, someone having a heart attack at 2 a.m. So I find a wide variety in it, and you know, it's a field where I still get to see the same people over and over, and so, you know, I wouldn't do anything else.
Thank you. Okay, so our next question. Are there certain mental health conditions that disproportionately affect underrepresented populations?
So I'll stick to mental health if that's my field. But in regards to mental health, you know, I don't personally believe that it is based on any type of race. It's more about, you know, the exposure to trauma, the exposure to the lack of resources, that survival instinct. Think about someone from utero whose mother had substance use or could not eat while she was pregnant. You know that through epigenetics that code is passed down to our children. So if the mother is not getting those resources, guess what? The child is already set back. And so we have to just be more aware of how all systems, you know, are people being fed? Are people being provided access to mental health resources? And I don't think it's based off of race, but it's more of access to resources, or more of a financial piece, or even living in rural areas, as you stated earlier. You know, if you don't have access to prenatal care, guess what? There's some things you're going to miss out on. If you don't have access to get nutrition, and the only place that you can eat at are Family Dollars, there's food deserts, guess what? You're not going to be able to fight diabetes, cholesterol issues. So it's really about recognizing what is the system in place around our individuals. That's why I don't like to say it's just cultural. It can be, but many times it's education, resources, and community.
Thank you. What were the effects of COVID-19 on minority groups compared to other groups?
And then people lose their employer provider healthcare insurance across the board, not just for minorities, but especially for it's not just the lost their healthcare, it's also their dependents. And so in that, we've seen a decrease in the number of screenings that do to screen patients for these medical conditions, and they miss out on early detection. I'm sure, we have others that can speak to that. Another thing I think kind of is to the COVID-19 aspect and how, I mean, there's so much data still coming in and servicing, but COVID hit some of the minority groups a lot harder than others. And I think part of that was their underlying condition. And everything in the news that you kept hearing was it was all constantly referencing an underlying this, an underlying that. Well, kind of going back to what Dr. Haddad was saying already, they do have an underlying, predisposition to diabetes, obesity, hypertension. So a lot of their chronic illnesses that they've already established were underlying. Or if they hadn't had it established, they were evaluated in emergency department, acute care, ACP office, because those underlying or chronic conditions were exacerbated by COVID-19. So I think it kind of was just a vicious little cycle we were in.
Without a doubt, COVID-19 disproportionately affected patients of color disproportionately. So if you look at any data on mortality or death rates, it was absolutely higher in patients of color, non-white populations. So Black population, Hispanic population. So if you put the same risk profile across the board, you're still more likely to die if you're Black or Hispanic, and you were infected with COVID-19. That's period. That's just statistics. It's just the facts. In our region, if you look at the data, the Hispanic population disproportionately accounts for the mortality in this region with our COVID deaths. So clearly, having underlying risk factors. So it's as simple as just if you're sicker, you were more likely to die from COVID-19, and multiple reasons for death. That COVID-19 generally was a respiratory virus that would lead to pneumonia, and then complications that happen once you get in the hospital and you're on a breathing machine. We saw a lot of cardiovascular complications or thrombotic complications, people having blood clots in their lungs, having heart attacks, having strokes. We also, you guys can speak to this in terms of, and I do not want to get into the politics of vaccination and how that was politicized, but I think we can say without doing that the vaccines, whichever company has a statistic, lower the chance of death or significant illness across the board. Populations of color, non-white populations, were less likely to have access to vaccination, particularly early on, and still less likely to receive the vaccine. So probably a multitude of reasons for that. So as a generic answer to that question, without a doubt, COVID-19 disproportionately affected population health.
In regards to mental health, let's think about it from a culture aspect. So for people of color, especially African Americans and Hispanics and even Asian families, their sense of community is through their religious environments, through gathering as a community. Guess what happened with COVID? That stopped. We're now afraid to be around certain people or illnesses, and we're afraid that we're going to get our grandparents sick, or we're now just afraid. So what I'm seeing right now is an increase of anxiety in regards to COVID illness and learning to integrate back into our communities. It's so much fear there right now. I would say that I see at least 15% of my clients are coming in for anxiety related to COVID, because they want to get out there, they want to see their family, but they don't know how to, because that stress is real, or their family may not have the same values in regards to vaccinations and things like that. So therefore, now there's some anger and resentment within the family. There's also been deaths in the family. So it's impacting not only the family unit, but the cultural aspect to how they even learn to be together. So I'm seeing a lot of our children that are coming in saying, you know, or there's some arguments. So I could really say that we haven't really seen the whole picture of what COVID has done to people in regards to their mental health. I think that we're going to see a lot more reactions, especially since this wave isn't supposedly over yet. So that gives more anxiety, like, when is it in? And I don't have an answer for them. So I'm like, let's do this better. But it's real. So that's my viewpoint.
Thank you. What are cultural factors that cause barriers for reporting and seeking treatment for sexual assault, sexual abuse, and domestic violence?
There are barriers, there's a lot of shame and stigma associated. There, not just with Hispanic cultures, there is a distrust of law enforcement system. There's the criminal justice system. There's distrust there. Kids don't believe that they will access. They believe that if, you know, reporting or seeking treatment, it will make the situation easy. So there's a lot of distrust. There is a see patterns of families kind of valuing on perpetrator, protecting. See this a lot with lesson and cases. There is a general want to disbelieve something like that exposes. It's a human trait. It's a human response. You know, most people have. So we see situations where children and adolescents will suffer abuse for years or to receive the treatment. So culturally, there are a lot of cultural aspects. There are also religious aspects. So religious aspects play heavily to the shame factor. The need to status quo. There are also issues with, well, if I'm going to be removed from my family, basically be shunned from my family, exposing this. You see a lot of dependency issues there. Children obviously for care. We see this with domestic violence. We see this with. We also see a whole other spectrum. We see issues. Whereas those victims, they are forced to. And there's a lot of psychological. There are many risk factors for something that's happened. That individual often women. Whispers. They are basically sold for funds or whatever the purpose is using them for. So there's a lot that goes into that as well because minorities are high risk for that. Anywhere where we see abuse, strife within the family, respect. There are just being able to identify it.
Okay, so we will take a moment to take some questions from our audience, and then we will return to the determined questions. This gentleman, right? Yeah.
So relative to sexual assault, and specifically males, especially within this kind of culture of machismo, what is the incidence of male reporting and what how do we go about their mental health presentation?
So that's a really good question. A lot of people think they associate sexual assault, sexual abuse with children and women because they are very high risk for that. It's a vulnerable population. But a lot of people don't know that here in the state of Texas, 1 in 10, it's estimated that 1 in 10 males have been victims. I want to bet that it's actually a lot higher than that. Males reporting sexual assault, it doesn't happen that often. It's kind of a rare, because of that machismo, it's because our society in general, for males across the board, they are taught from an early age that you have to be strong, this can't happen to you. So it's viewed as a sign of weakness that this could happen to you. So it's the statistics say 1 in 10 males. So but I bet that it's a lot higher. It's just very underreported. I would just add on to that. Military sexual trauma is very much a topic of discussion within the forces, and so it's very much underreported as well. One thing that research as far as evidence-based research and helping these victims understand process is really about processing. So, I myself, research shows that cognitive processing therapy. We also have social workers and therapists. Prolonged exposure and EMDR, which is eye desensitization, movement, breathing, something. Okay, EMDR. I don't know. But there are evidence-based research modalities that we know have been beneficial in helping people process trauma. That's really, but first we got to open the door, right? We have to make sure that we're listening, that even if we, especially for our children or our older aging adults, that we report, because the biggest fear is that we're not even getting report because they're afraid that it's going to come back and that people are going to now judge them and they're going to be ostracized by the community. And that's a big fear within people of color and culturally in our environments. So we have to first report. We have to get people strong enough to say, you know what, you're doing it for the child. You're doing it for those that need it more than anyone else. So if we can change that perspective, it's really about understanding that when you do report, it doesn't have to come back to you, but we gotta get the right eyes on it. The first thing I tell people when I'm like, hey, I'm here about trauma, but let's talk about it. I want to know because many times people are misdiagnosed because they don't even want to report their child. They want to say, oh, it's anxiety, it's depression, and you have all these other things. You have conduct disorder for our children, and when really it's trauma. Trauma affects people so much more differently. Affects how they think. If you look at the research when it comes to our brains, how our brains can be changed from trauma. So that's why it's super important that we're trauma informed on all aspects. Because before we want to diagnose, we have to recognize, is this something that we can help change?
Thank you. Do we have any other questions for our audience? Okay.
I actually support being a law enforcement specialist. This is a trade, especially in St. Joe, that minorities with the older generation of children did not believe in reaching out for help with mental health. Do y'all see it? Younger generations are coming out on the skateboard, globalized, and see around the world that is starting to change with generations. And then the other part of the question is, I don't know, especially in social work, that mercy is kind of overused and the quick thing we go to instead of trying to go for outreach. It's like,
That second one is a loaded question, but I'll start with the first one. So the first one was, are we seeing more people accepting mental health care in our younger generation? And the answer is yes, definitely. And I think as far as our rural communities, what I'm seeing is because we're actually talking about it, and we have implemented at West Texas and community with NHMR, we've implemented the Zero Suicide program. I think that has opened up people's perspective about just talking about suicide, because now we don't have to just take you over and put you in a patient hospital and load up ERs because people are depressed and going through a crisis. Now we have therapists, and we are training with Shannon as well to identify those crises so that they can send them over with therapists within 24 hours and have those conversations. Also, SAISD, the school system, now they're being trained. They're being trained to talk about access to resources in regards to mental health. They're saying their guidance counselors who have limited resources, limited abilities to do counseling in the school setting, right? They can't do that. That's not their purpose. So now they have a resource to refer them out and give their parents. So it's really about connecting those community resources, partnerships. That's what's going to change our rural areas. That's what all the research says. And that's why I think this area is becoming more aware about what's available. Now, in regards to the emergency attention, that is ran by an organization in our community that doesn't have very much financial support. It is very difficult to handle some of the crises. You have amazing officers that don't have any idea about what, right? Their first idea is, let me protect whoever is in harm. And I don't even know who's in harm right now, but you're screaming, so I'm gonna take you down, right? So, and then we gotta understand, where is that crisis coming from? Is it because they are, let's say, substance use? Or is this because they just had someone die? Or do they have schizophrenia? If you've never dealt with any of those diagnoses, it's really difficult. As a clinical therapist who works with clients with psychosis, let me tell you, it is very hard. I have to take a break or go over to my own therapist and be like, I'm full of anxiety, right? It's difficult. So we can say that the program is a failure. I'm saying that it takes community action to say, hey, let's find some funding. Let's put the funding in the right places to help. And let's bring attention and awareness to the need that we need to talk about those emergency detention orders. Because yes, that is a problem, not only here in San Angelo, but everywhere. And it starts with identifying the problem and finding the right people that want to make a change. And also getting together and building those community resources like we do now with the Zero Suicide.
Does anyone have anything to add to that?
So kind of just touching base on the first aspect of the question, definitely what I'm seeing like in my practice will be, I'll have a young, my patient population is like on average 18 to 25. So I have these students that come in and they're like, I have never talked to anybody about mental health. My parents didn't believe in it. It was not a real thing. And so we'll kind of do together with counseling, we initiate medication, and then you can see they just turn over a new leaf. And it's kind of like, then their parents believe it. Then they believe there really was an underlying issue, and we were able to kind of get through to them. So I think we're slowly breaking down the stigma, maybe with that older generation, but the new up and coming generation, they're living it. They're seeing the positive of it. And kind of just like what you were referencing about the school age kids, like my son, he's 12, he came home the other day telling me that their counselor, I think they brought, she was coming in and talking to the classes about just depression. It was depression she was telling them, but they never used the word depression. It was other things like, are you feeling really tired? Do you not enjoy playing basketball? All of these things. They came home and it just opened the door of communication for me. And then I kind of reached out to my little mom's group and like, hey, if y'all's kids have questions, send them to me. If y'all don't know, come talk to me. I'll help you kind of navigate what I can help to get that. So hopefully we're slowly breaking it down.
Thank you. Okay, do we have another question?
If you go back and talk to your college age self, what would you tell yourself? Or what would you do differently to become a better a healthier person now? Based on your experience and based on your ability.
Well, that's a great question. I'm going to start with the basics. Every time an application that comes in talks to me about insomnia, anxiety, depression, difficulty with concentration, I always go back to the basics. How are we eating? How are we sleeping? And are we exercising? So looking back on my college days, I didn't eat good. I mean, we all ate stripes burritos, right? I definitely was not exercising on a regular basis. And sleep, I think, was kind of non-existent. So kind of looking back at that, I'm like, gosh, I just want to kick myself. I could have been so much more productive thinking back about that. So kind of for me would just be to go back to the basics, get some good quality sleep, try to eat some colorful fruits and vegetables every once in a while, and go outside and take a walk.
Alcohol is not your friend. Well, it's not my friend. No, seriously, like, understanding your coping skills, right? What do you do to cope? I mean, we say that word, what's coping? I mean, I isolate. Oh, is that very healthy? You sit in your room all day and you just get sadder? As a therapist, what do I tell myself now? I say, talk to yourself like you're your best friend. Give yourself self-affirmations. Tell yourself you're great even when you don't feel you're greatest. Find the good in life even when it's something bad you can find like the school setting. Find a support system. People you can talk to that will listen, that will be honest, but also respectful of their values and what you can handle. Because not everybody can handle me, right? Like, I'm very blunt. So, I don't think you're prepared for this. Also, self-compassion. Allow yourself to make mistakes. I don't think I would be the person I am today had I not had the words. But at the end of the day, it's about my decisions. So it's really about where you are in that moment and recognizing that, yeah, growth's going to be tough. But what do you surround yourself with so that you can make it and keep on going forward? Because That doesn't stop getting tough when you get out of college. It doesn't stop getting tough when you get married. It definitely doesn't stop getting tough when you have children. Because let me tell you, 14-year-olds are a whole mess. So give yourself some compassion. Say, learn to set boundaries. Yes. Boundaries is a big, and I know I'm not some I've been a nurse pretty much my whole adult life. 19 years old. And when you're young like that, you have all the energy in the world. You think it's more, you can do all these things. 4 12-hour shifts in a row, you know, and go to school full time and all this. But we need to learn to set boundaries. Don't, you're going to burn out. If I could change anything, it would have been to work on that mentally from the get-go, because it is very hard to say no.
Well, first I was saying to surround yourself with people like this. So, speaking to a group of undergraduates and members out there in the world out there, that's not here with us in person, I would say particularly for myself, since you directed it to us directly, it's always hard retrospectively to look, but I try to stress to people that ask me, you know, so it took there was a lot of formal education with undergraduate degrees and then medical school and then postgraduate training and residency program and fellowship training. So I would probably look back and say to enjoy the moment and not just focus on the end goal. So to remember the whole process and enjoy it. And I try to tell people that ask me, well, how long? I always get, how long does it take to be a cardiologist? I'm like, well, let's not worry about that. What do you want to study or what do you, and I'm not saying I did that because I'm sure I was just like that. So I'd probably say, just somehow, it might be cliche, enjoy the journey and not just focus on the goal. I mean, now, you're going to have to focus on the goal to some degree, whatever that goal is. But remember, the steps along the way is what life is. Sometimes we lose track of and turn back around, and as time goes by, because I have a 14-year-old and 11-year-old, and I can remember moving here, and they were both babies, and I'm like, what is happening? And we were neighbors, and all our kids were little, and so I saw her children recently, and I'm like, oh my gosh, this is what's happening. So this time will pass by quickly, so enjoy it, get out of this experience that you guys are having now, everything that a undergraduate university has to offer. So if any of you are pre-med in this room or whatever, you're focusing on that, remember what else this university has to offer that's outside of your area of interest that you're not going to get after your and throughout life, don't just focus on the end goal, maybe, enjoy the steps along the way.
Thank you. Any other questions from our audience? Okay.
So for minorities here listening to we have relative to chronic conditions, like hypertension, is there anything like barriers or comprehension of with these people presenting with these, whether it's in the middle of it, late stage, charge, what is it left? And are they in your things that's
Yes. So that goes, I mean, it's it's a deeper question, and I think one that we're starting to answer as we none of us, like this forum, I don't know exactly its title, but it was on mental health and medical disparities in minority populations. So again, so outside of structurally conceptual things that lead to it, like food deserts, right? So if you don't have access to income that will support anything except bad food, that then perpetuates, so all of those stuff that you talk about, that we are identifying and we can lump that into structural issues that as a society we look at, people might die or not. I think most literature and most mainstream bodies, professional organizations are identifying these and addressing these. But then it also comes back to other discrepancies we see that probably have to go back to the and that's a much more difficult subject. That's a much more, it's easier to all merge into well, there's a lot of structural inequalities, systematic inequalities, and it's a systems issue that we'll fix versus identifying the individual issues. So the American Heart Association, and I'll speak to this as a cardiologist in 2020, has started an initiative to look at the individual practitioners. So me as a cardiologist, when I'm seeing patients, memory population, how are my practices different? Okay, so not just all these things we talk about and identify, but you might practice differently. If you look at the data, the answer is going to be yes. And so that's just the truth. Now, none of us like to identify and we can also know about being, but it's, if you look across the board, it's to be the truth that why is that? Do we have more difficulty talking to certain patients? Do we have more difficulty believing that they're going to listen to our recommendations? Or I don't know, but yeah, and trouble, we see higher readmission rates, we see higher non-compliance rates. So, we first have to admit that that's happening before we even begin to address.
Just to add on to what you were saying, I know one of the things that I feel was very beneficial for my studying when I graduated was the integration and collaboration of services. So for my senior year, they not only brought us social workers, but they brought in public health, they brought in nurses, they brought in first year med students, they brought in dietitians, first year dietitians in the master's program. They brought in all of these different career paths. They made us sit at a table and learn how to connect the pieces. What do you bring to the table that I don't have? What do you bring to the table that I don't have? A lot of big inner cities have that. They're in place in their hospital system. So when we have a high-risk environment, have a team that we can talk about and create services and a follow-up plan, and we're ensuring, we're checking to make sure that this client is covered. That, yes, they're high risk, but they also might have a cognitive disorder and not be able to understand. So we bring in their families, really that coordinated care. And that can be very difficult in rural areas. 2 hours away. Yeah, but we gotta do something. Maybe that's something that we have to implement. What would that involve? It would take somebody from Shannon saying, hey, this is what we're going to do, because they are the primary medical center, but they are treating 15, 16 counties. So it can be very difficult. It's a big problem. We know that a lot of money is being brought into the rural areas in regards to care, mental health, and we're trying to pay the nurses and all to come out to this area because it is difficult to keep students that graduate here. So if you guys are thinking about leaving, I want to say keep us here, stay, right? Because it's important. We do need more clinical therapists. We are undermanned when it comes to licensed professional counselors therapists, sure nurses. Are y'all under management? Are you under management?
I would say physician and providers probably won't, but everything else, without a doubt. Some of the students here at Angelo State that decide not to stay at Shannon, tell us why.
Yeah.
But I mean, you know,
What do we need to bring into our community to keep you guys here? So we need to talk and ask y'all.
I know that's, and that, we have a, all, a great nursing program here, there's a great nursing program here that's great. Allied health programs at this university, Howard College, and we should be able to, so if we're not, we gotta figure out why.
First, as medical practitioners, it's important for us to do a first of all, a personal balance assessment. Self-reflection, because we're all human, we all come to our patient's bedside with our own views of things and our own prejudices. And we don't even realize it sometimes, and sometimes we project that on the situation with our patient. That can how they receive their care, that any future care we choose to receive. It also plays a heavy role in patient education. So patient education is one of the most special things that we do as nurses. That's one of the most important things that we do. And, talk about educating patients with appropriate materials. Are we educating them, children competent with that? Are we see those language barriers? Do we have the tools to do that? Do we know where to seek assistance for those things? One of the things that we talk about a lot is what's handouts that, and I'm sure all of us have been to the doctor before. Handouts given to us on patient information. Been in the hospital, get discharged, they give you this big old packet of paper, and that's supposed to be your patient. But what do most patients do with that? They throw it away. Because nobody has time to read. We need straightforward, bullet point, why is this important? What is it, what's going to happen when I'm supposed to do this? What are the risks and benefits? What do I need to do? That's what these patients need to know. We need to make sure that they are receiving this in their language, in their primary language. Because if you look at a lot of websites like hospitals and stuff, you just have to go and do a random search. Is there a separate page for Spanish speaking? Most people don't know where. It's all in English. So, Spanish is what the predominantly spoken 7 languages here in this area, but there are others. There are others, patients come from everywhere. And if they can't access their education and, be able to research things on their own language, that increases their health literacy. And so that makes that impacts them as well.
Thank you. Do we have one more? Okay. So, non-white Americans die from heart disease more than anything else. Can you shed some light on how racial inequalities are manifested in cardiovascular disease?
I think that's probably the question I think we spoke to it, so,
Okay.
I don't know more than that.
Okay. What are some of the factors that might contribute to minorities having difficulty reaching out for resources?
Well, we touched on geography is a big one. We also talked about things that cause lack of access to care, financial barriers, lack of transportation, lack of ability to pay for care because of loss or lack of healthcare insurance. those are probably some of the two biggest issues that we see, and this is why we should still be there. And I think though, another thing we need to focus on is if we break down that barrier and we get them there, we gotta take advantage of when they are there with us. One of the things that we've started doing at our clinic is every year patients will get a PHQ-9 and a GAD screening. So sometimes you come in for a sprained ankle and then the next thing you know, you're filling out this form that's related to, you know, how well are you sleeping? What is your interest level? Do you find pleasure in activities? And our patients are a little like, it's just my left ankle that's bothering me, nothing else. And then, but they fill it out and it opens up these doors to a lot of communications. We're trying to take advantage of when they get there and then they don't even, for instance, over at the ASU Student Health Center, they're not even aware that sometimes we offer those services, that we have the capability to start the process, to initiate medications, recommend counseling, provide those services. So I think also capitalizing on whenever, you know, we spend all this time getting the patients there, convincing them to come and see us, let's take advantage of it.
And I would like to add on to that. Also, how do we even get them to the door? How are we going to them and saying, hey, guys, we want you to come
That's
here?
why we check on with the hurt ankles.
You know, sometimes we do have to go to their events, right? And say, did you know this is available in your community? Hey, I'm here, I'm available, we have some research, let me just talk to you. Environment that feels safe and interactive, right? Like, let me just have that conversation about mental health. Let me talk about some financial issues that, you know, might be causing strain, what resources you can go to. I know with what's the Concho Valley Suicide Prevention Coalition. You know, I had brought up, you know, we have a lot of clients that suffer from homelessness, right? Homelessness is a really big issue in our community. And, you know, I brought up, I said, you know, let's just go to their campus and give them some information. And someone in our coalition respectfully said, well, you can't just walk up into someone's home and walk in and say, hey, these are your resources. So it's about building those connections and being invited in. Understanding that they might not open the door the first time we come up. Being okay with that and saying, I respect that. I want you to know that I'm still going to be here and I'm still providing this resources without any, you know, denial. Saying that, you know, at the end of the day, I'm here for you and I'm not making you make that decision.
Thank you. And for our final question of the night, in addition to race, are there other population groups that are hesitant to reach out?
They are very yeah, definitely. I was gonna say, yeah, LGBTQ for sure. Because, you know, we're in a rural area and everybody knows it. So it can be very disheartening if you identify as part of that community, but that might not only just affect you, right? Their church family are really hesitant. They are so small to identify their words, like they're not being true. I would also say, you know, what we've seen at women that have domestic violence, they're afraid that if they reach out for services, that people are going to say you have to leave the house or leave the spouse or leave whoever is the abuser, which that isn't. Their purpose is to be where you're at, but still providing you with resources. Ability to talk about it. So that fear of not going and seeking out services because that fear of this the other that might harm them, but also that if I come to you and I didn't accept what you said, like such as leaving the house, then you're never going to help. So we have to change
that narrative that those resources are to be for, that's gonna take a community that bring them to like open arms for LGBTQ community. As far as the shelter, the family shelter for DV victims, you know, knowing about those resources in our help streamline them to the who are not U.S. citizens. They are also very high risk because there is a fear of so that's a very big fear. A lot of the patients, they don't understand that to facility when they need that care. I'm going to call, you know, the authorities. I want to treat you. It's not our goal. There is a huge, and so those patients, they wait to see until or they avoid treatment. So
See, with women as well. So in terms of cardiovascular events, the other population we see that tends to present late and tends to have worse outcomes. So there's a lot of speculation of why. Usually they've got a lot more to do than are, but a lot of times the symptoms that women have, acute heart events, are a little bit different than the stereotypical things we think of when you're having a heart attack. But it's quite clear in the literature that women tend to present later in acute coronary events, and their disease processes tend to be worse, and their morbidity, and unfortunately their mortality with those same processes tend to be higher because of that later presentation.
Okay. Well, that is all the time that we have for tonight. I would like to thank our panel members for coming tonight and offering your valuable time and expertise. I think we all learned quite a bit from you guys tonight. And I would also like to offer some resources to our Angelo State University students. We do have Angelo State University counseling services available to all of our students. And we also do have the Jackson Clinic where Mrs. Toby Redden works. And for anyone who is not an Angelo State University student and who would like additional resources, you can reach out to us at Angelo State University Counseling Services, and we will be more than happy to help you with a referral for mental health referral, or any other kind of referral you would like. Thank you all so much and have a safe night. Thank you.